Good afternoon, everybody.
Here, here.
Oh, okay.
Don't
No,
fight.
go ahead, go. It works. It works better than my little Tibetan things. Do it again. There you go. Okay. Good afternoon, everyone. Thank you for taking time out of your busy day to come and join us to learn about our rural program here. This presentation is recorded, and please take your survey at the end because we really take your feedback seriously. So our rural program is really pretty special. It is a nationally recognized program for its excellence in rural workforce development. And we're welcoming Dr. Mark Deutchman, Dr. Roberto Silva, and Dr. Melanie DeHerrera to present the program to us. So about each of them, Mark Deutchman is a professor in family medicine, and he's also Associate Dean for Rural Health at CU here, the founder and director of the Rural Track at CU Anschutz. And that is a program that is for students that are planning a career in rural medical practice. And it's a national model, and it's actually been scaled up to other professions in the school through Rural Workforce Development Initiative. He practiced family medicine in rural Washington State for 12 years. And he's now involved in teaching fellows, residents, and mostly medical students, preparing them for rural practice. Roberto Silva is assistant professor of our School of Medicine's rural program, and he got his medical degree from University of New Mexico, been in practice for more than 20 years. And he also was recognized with the 24-25 Golden Stethoscope Preceptorship Award for outstanding patient-provider communication. So wonderful role model, and showcasing that invaluable connection that goes into both teaching and practicing. And then finally, Dr. Melanie DeHerrera, who is a newly minted doctoral of education. She has been with the department since July of 23, manages a rural program, and is a lot of times is the one that actually makes things happen behind Roberto and Mark, as I've come to know. Master's degree in public administration, University of Colorado, Denver. Bachelor's degree in family and consumer sciences, and she just recently completed her EDD from University of Colorado, Denver. So with that, let's welcome the leadership of the rural program.
Thanks, Myra. Okay. So thank you all for coming. We really appreciate you being here. Our rural program team is really happy to be able to make this presentation. And you've already had some of us introduced, but we need to recognize other members of our team. Melissa Darzens is right back there. Raise your hand. Julia Kendrick is another coordinator. She might be online. I'm not sure if she is. She's in Atlanta right now. And Lou Heimerl is part of our team, but is not here today because she's proctoring a test. I think that's what's going on. Three of our faculty members will be here by Zoom if they can. I think Dr. Megan Leike is zoomed in. She's on the Western Slope. And Dr. Mandy Swanson might be zooming in too. And Liz Gunderson is on service at the hospital. So we're still actively involved in teaching. And then our entire first year class is in the room. They came for the food, I think. So, okay. Our agenda for this afternoon is to talk about why the rural program exists, to go through our goals, strategies and curriculum, talk about our outcomes, funding sources, spin-offs, and then of course, talk about the future. So the first question is, why does Colorado need a rural program? And diving into that, just look at the map. 2/3 of Colorado's counties are rural or frontier. The rural are in light blue and the frontier in dark blue, as designated by the State Office of Rural Health. And in case you're wondering, frontier means fewer than 6 people per square mile, or where there's more cows than people. And then if you look at this map, This map shows that most of Colorado, actually urban and rural, are short of primary care. In rural communities, family medicine represents the biggest source of primary care. So this map essentially shows where there's a shortage of family medicine, which is pretty much everywhere, which is relevant to our goal here. Even though the School of Medicine historically would admit people who were interested in rural, interested in primary care, interested in family medicine, guess what? When people spend 4 years in an academic health center that's predominantly run by and with a subspecialty model in mind, often those interests end up falling by the wayside. And so prior to 2005, there was no organized program to provide a rural viewpoint and give clinical experience in a extensive way to our students. So that's why we have why we started the rural program. I will turn it over to Melanie to continue.
Thanks, Mark. So as Mark mentioned, the program was founded in 2005. I had the opportunity to join this program in 2013 and be part of its evolution. We started as an elective track and have now become a program as the CU School of Medicine curriculum has evolved. We typically have about 10% of the medical school class in our program. We do emphasize primary care and particularly family medicine, but we're happy with any of the students who decide to practice rurally. And our goal over this last 20 years has remained the same, which is really to increase the number of students who will enter and remain in practice in rural areas of Colorado. So in terms of our curriculum, I think one of the most important pieces is having a selective admissions process. So we're really trying to attract and admit students who we think are likely to practice rurally, but also have an interest in participating in our program. Our goal is to develop a like-minded cohort of faculty, students, and staff. We offer the students a pre-matriculation orientation to cover topics that we think are important, also get to know each other and form that cohort. We have weekly seminars and workshops in year one. We just came from a chest tube workshop with the students. During their second year, they have a rural longitudinal integrated clerkship that we'll talk about in a few slides. And then in years 3 and 4 in particular, we offer some different rural electives and different clinical experiences, as well as support with any research opportunities and what students want to explore. And then we also provide them with ongoing mentorship, residency advising, and we have different social activities throughout. And then our goal is really to form long-term relationship with these students. We survey them annually, even as they go into residency and practice, so that we can track our outcomes, but also so that we can use that as an opportunity. That's a time where they reach back out and maybe are looking for jobs, or if they've started at a practice in rural Colorado, hopefully can start precepting our current students. And then some of the pieces that we're trying to convey as part of our curriculum, really promoting a generalism and can-do attitude amongst the students. We really try to emphasize community engagement, and especially as the students are in their sites across the state, really thinking about their leadership role as a physician. We're trying to cultivate rural knowledge, skills, and attitudes, help the students understand the unique features of rural life and people, really recognize some of the health disparities that exist in rural communities. And then also our goal is to really help the students as they form their professional identities during their time in medical school. So I have one of my first year students who is here and going to share a little bit about herself and why she joined our program.
Hello, everyone. I've been talking. Oh, wow, thank you, everybody. It's been a minute since I've talked into a mic, so if I'm too close, just let me know. As Melanie said, my name is Addie Feek. I'm a first-year medical student. I'm technically from Tabernash, Colorado, which is, see, someone knows it, Green County. By Winter Park Resort, that might be what you're more familiar with. I grew up in a community that is considered remote resort and had a very interesting medical landscape. Most of the care that I had throughout my life was given by family medicine physicians who worked in independent practices. Specifically, I saw the same father-daughter team from literally when I can remember, up until the time when I was shadowing, wanting to become a physician just a couple of years ago. And I really started to appreciate just the diversity of care that was offered in that space. For me personally, I would see Kelly giving out flu shots at the local hockey rink during games, which is not normal practice, but was normal for us. Or, calling people in on New Year's Day when I broke my arm doing flips off the bunk bed, and Dr. Kennedy was in the office the next day. So just like a really unique perspective of medicine. And then as I started shadowing and seeing more from the provider side, I realized just how every single visit and every single case is so different, and just that kind of breadth of knowledge that comes from being a family medicine physician. And just like the overall level of connection you have with your patients when you're in this space where you can watch them grow, especially in a rural community. So that was really what drew me to being a physician kind of in the first place. As a first generation physician, this really was my experience. And then now being in the rural program is one of the major reasons why I'm here.
Thank you, Addie. And then here's just some photos from some of our hands-on workshops, which the students, of course, absolutely love. And then I'm going to turn it over now to Roberto to talk about the outcomes of our rural medical education program.
Okay, thanks, Melanie, and thank you, Addie. So this is a picture of our graduating class from earlier this year with some of the faculty there. I would like to talk a little bit about the outcomes of the program. Now that we've been around for a long time, we can tell you about where our graduates are. As of this year, 288 MDs have graduated from our program. So let's talk about that. So these are the residency match outcomes for our graduates from the first graduating class, which was in 2009 up until this year in 2025. As you can see, the graduates, they enter a wide range of specialties. Nearly 40% of those choose to enter family medicine residency. And I'll talk more about how that compares to national and our school averages in some upcoming slides. Out of the 288 graduates that I mentioned, now over 200 of them have completed their residency and in some cases fellowship training and are now in practice. So 37% of all of those grads are in truly rural practice, and we use a pretty strict definition of rural in our group, and there's lots of definitions out there, but we keep a pretty strict definition for when we say someone is practicing truly rural. You can see that 43 out of those 78 are in rural Colorado, and others in rural communities in other states. If we look at all of the graduates again, 50% of them, half of them, are practicing somewhere in Colorado. And bouncing back again to those that are in rural practice, so the 78 of those that are in rural practice, you can see 59% of those are in family medicine with a mix of other specialties, and this includes the most recent folks that have finished training and have entered practice. And we've done a pretty darn good job of keeping track of where people are. We don't have 100% of where everyone is, but pretty close. So you can see this big list of where all those grads that are practicing in rural Colorado are. And if you know the geography of Colorado and run down this list, it's kind of sprinkled all across the state. So there's lots of the names of these places you'll see come up as our teaching sites as well, coming up. But they're kind of on all sides of the state. All right, what about those that are not practicing rural? So there are a number of our grads practicing in urban Colorado. You can see a lot of those are in the Denver metro area, but are also practicing in various specialties in some of the other urban areas of the state. those that are in urban Colorado, including the Denver metro area, 40% of those, or 25 of them, are practicing in family medicine. And you can see the breakdown there with the other specialties of folks that are still in Colorado, but not in rural places, but in urban places. So I highlighted that that family medicine portion there because I want to talk about the importance of the program, not just to rural, but to family medicine as well. After all, that's our home here. So I'm gonna talk a little bit about what has happened over the last 17 rounds of matches with CU. So look at the blue bars there. For the moment, what you see are the blue bars that represent students that were not in the rural track or rural program. So that's the match rate into family medicine. You can see it's kind of in that 7 to low teens %. And now I'm going to add the percentage of graduates that were in the rural track or rural program and their match rate into family medicine. And the last bars there on the far right are kind of the grand total for all these last 17 groups of matching students, and you can see it's over 4 times the rate of non-rural track students that actually decide to go into family medicine. And there's a number of reasons that we believe that's true, and we can talk about that a little bit later. I'm going to switch gears for now and go from outcomes to talk about what do we do? How do we get there? How do we get these outcomes, and how do we get to that educational mountain? Melanie mentioned the first year curriculum, which involves a lot of workshops and getting to know each other and kind of planning out the second year. I spend a lot of my time working on the second year, which, as you know, in this medical school is the core clinical year, in which students, all CU students, do this longitudinal form of clerkship where they're doing their clerkships simultaneously. So all of those things listed there, family medicine, ped, psych, etc., they're doing them all at the same time. Now there are students doing that on this campus, at Denver Health, in Fort Collins, and multiple places around the state. We've developed a number of rural sites where our students spend over 9 months at that in that rural community, after a couple of months of doing some inpatient work and some prep experiences here in Denver. We have over 400 faculty preceptors that are sprinkled around the state, and a lot of those are those graduates that I was talking about earlier. So as of today, so right now we have 19 students that are in these 15 communities around the state. The closest one is in Fort Morgan, which is about an hour and a half drive from here with good weather and good traffic. The furthest is probably, right as of right now, it's Durango, which is near the Four Corners area, which is a pretty far drive. I think you can drive to Mount Rushmore quicker than you can get down to Durango from here. And so even some of these places that look like they're pretty close to each other on the map, the drive is a little different than the way the bird flies. To develop and operate an LIC like this that's spread all over the state in a dispersed model it's a lot of work. We interact with all of these and much more. I definitely did not include all of the sites that we work with. But to interact with all these different organizations and all these different communities, it requires a few things. It requires relationships. It means knowing these people and where they live, what they do, what their family is like. That means not just emailing them. That means visiting these sites and learning the communities. I describe it as monitoring the vital signs of all the local and regional, national economies, politics, like the healthcare trends, which doctors are leaving, which are coming, which hospitals are at risk of being closed. So you also need to, as I mentioned, have have a good set of tires on your car, because you got to maintain these relationships. You got to get in the car and drive. We're lucky now that we have some folks on our team that are in other places in the state. Before that, it was the three of us doing probably over 4,000 miles of driving every year. Now we haven't counted it up recently, but it's on that order. So like I said, it's lots of windshield time. It's kind of knowing the communities and knowing the people that live there, and knowing the doctors that practice there, and all of the nuance to that. So as I mentioned, lots of those preceptors that we have, they were students here and they were in the rural track. And so let's hear from them. I'm going to have ask Mark to introduce you to some of our graduates.
Thank you. Here's your glasses. Okay, well, what we're going to do now is zoom in some folks to talk about their experiences. And so first of all, what I want to do is just tell you who you're going to hear from. The first person is Michael Persinger. Michael graduated in 2024 and is now a second-year resident in the CU Family Medicine residency. Next, we'll have Tom Claggett, who graduated in 2017, who did his family medicine residency in Idaho and then returned to Colorado, where he's now practicing in Montrose and precepts current students. And then we have Thaisa and Cole Weedell, who were 2014 graduates. Thaisa did her family medicine residency at St. Joe's in Denver, and Cole did his urology residency here. Both practice in Salida and precept current students. So I'm going to ask Michael to unmute yourself. I saw you there, and say hi. And Michael, maybe you can tell us about your experience and your career choice.
Yeah, definitely. So like when I came into medical school, I was kind of undecided in terms of what I wanted to do. At the time, I had joined the rural track because I knew I kind of wanted the more earlier hands-on experiences with some of the workshops, and I had met with some other kind of students in the rural program who like really talked about that their rural rotation was so much fun. They got a ton of hands-on experience, and it was just like really kind of really informative to the career choices. And so that's kind of what led me to participate. And then when I did my third year LIC experience in La Junta, like I just very much knew like family medicine is exactly what I wanted to do as a career. It was so fun getting to be a part of the community, getting to, see patients in clinic, see them in the hospital. Like there were people that we delivered them and then would do their follow-up in the outpatient setting. And so like getting that chance to really be a part of their care and kind of follow them from location to location was really fun. And I saw that was like really kind of what drew me to family med. The other half of that too was just like with family medicine, like the chance to be like an advocate for your community. And that was something I really appreciated about the rural program, was that part of our kind of experience in these rural settings is to make like a community engagement program. And so like getting to work with like the volunteer office at Valleywide and trying to figure out ways how to address like some of the community needs was like really, really fun. And really just kind of, again, like reinforce that decision that, family medicine is for me. So right now I'm in my second year. I'm tentatively planning on doing a geriatrics fellowship afterwards. And then if I can convince my wife, probably going rural. But outside of that, I think I'll be sticking in Colorado.
Thank you. All right, Tom.
Can you see me?
Yep.
Excellent.
And you are full screen, man. You're
I would say that my participation in the rural track definitely made me feel way more confident in what felt like a big leap before going, because I grew up in the Denver metro area, but I always kind of felt that I would be a lot happier if I was living in a more rural area. So having a chance to get out of the city and see what my career could look like before I made a huge commitment, before I took relocation money or signed a contract or anything like that. Just seeing what it could look like was putting my mind at ease that this is the thing that I want to do. It was so much fun to build friendships with the communities that I was working in, and seeing how much more satisfying a job as a doctor could be if you were integrated in your community. And when you work in a rural area, you are a fixture, and you are seen, and you are people will come up to you outside of work and ask you for things. And that is good and bad, but I'd say largely for me, I'd consider it an honor that people appreciate my insight. Um, so the opportunity to go on on these preceptorships or rotations was so fulfilling. And now as a practicing doctor in Montrose, and seeing patients here, and helping with hospice patients as well on the side. Having students is such a fulfilling way. I guess for me, it feels like something that I would say I'm obligated to do, because I received so much care and support from all of you when I was the student. And so I certainly felt like I owed it to everybody to carry that forward, and to hopefully draw more people into this. It's fun to stay connected to the campus. It's fun to hear from you all, and hear what's going on at the university. And I'd say to that end, like, the mentorship hasn't ended. And there have been times where I have uh, called Dr. Deutchman still, and asked him for his advice or his thoughts on thing. And I don't think he gets paid for that, but I still benefit from that, and I really appreciate that.
Well, you pay us back by precepting. Tell us what it's like to precept students in the same program you came from.
It's very fun to do it. It is hard work, but it's so fun to see them, especially in this 9-month curriculum now. It's so fun to see them coming in anxious and green, and just watch their trajectory just take off a few months into it, and become so confident and learn so much. It's really profound.
Thank you very much. And has this been okay for your family?
Working in rural Colorado,
Yeah.
it's been great. It's been absolutely great. I would say my commute to work is 5 minutes. We have great friendships all over where we live, and when it comes to life outside of work, I don't think we could be happier.
Good. Thank you very much.
Yeah.
So next, there's Thaisa and Cole. I don't know if you're both there. I'm looking at this sea of faces. I know Thaisa is there.
I'm here. I can let Cole go first though if he wants to. He's no longer.
I'm
Cole, you there? There you go.
yeah,
I'll
I'm
let him
here.
go first.
You're on, Cole. I think.
Okay,
Cole,
can
we
you
can't
hear
hear
me?
you. Now we can.
Yeah.
Okay. Um, yeah, I think the rural track made a huge impact on my career decisions. I went in with kind of an inkling that's what I wanted to do, and came out with a certainty. And I met my wife in the process, which was also pretty neat. And we have, shared life goals, which I think was helpful. But yeah, I mean, I tell the medical students this all the time, that it's really nice that you're able to visualize what practice looks like on the outside, because particularly in my specialty, which is a surgical specialty, you get kind of a very biased view of what practice looks like, because it's a major, tertiary care center where we train. And so for us, it's important, I think, as a student, to kind of have a goal of where you want to end up. And that's what the rural track gave to me. And I couldn't be happier with that. I think early hands-on experience, and also just kind of being able to picture yourself practicing where, in a rural setting, I think was super helpful in experiencing those things. Also, it gives you something to look forward to. I think as a student and a resident, sometimes it's such a slog that it's so nice to be able to be like, okay, there's some light at the end of the tunnel. This is what my practice will look like after working 100-hour weeks, or I guess you can't say that, 80-hour weeks. now I love precepting students, and I think, I really try to expose them to the surgical side of things and how much of an asset you can be if you have surgical training to a small community and the surrounding community. So, I serve a lot of South Central Colorado. I'm not a family medicine physician, but I work very closely with a lot of them. And it gives me goosebumps every time when I introduce a student, say, this is so and so. They came from the same program I did, and I'm helping train them. And it's just a really cool thing to be a part of. So it means a lot to me. And I've tried to take, students who are particularly interested in surgery under my wing, and it's been really fun.
Well, thanks. It means a lot to us too, Cole, to have you teaching our current students. Teiza, what's your story?
Hello. So I trained in family practice, but I've worked as a hospitalist, and I'm the hospitalist director now in Salida. I would say for sure the rural track made a huge impact in sort of in my trajectory. Obviously, of course, meeting my husband, and then sort of as we did rotations throughout rural Colorado and got to experience what life would be like. I think we both felt early on pretty confident that that's the path that we wanted. And so even throughout our training in the city, we kept in mind sort of what ultimately practice would look like. I made sure to get extra experience with the understanding that I would be practicing somewhere more rural in a less resource dense setting. So I think absolutely the rural track got a huge part of us getting to where we are, living in rural Colorado together and having a family here. Practicing in rural Colorado, I'd say for us, it's amazing. We love it. There's different challenges that exist in the city. I think overall lifestyle and having the access to things and having, the freedom to be able to raise a family here is amazing. There's things where it is hard. You wear multiple hats. You end up taking on numerous administrative duties. You have more limited resources when you're dealing with clinical situations. And so it definitely, it takes some getting used to practicing things on your own. We really love taking on the students. It's really cool for me to be able to see them kind of grow throughout their time here. And I love that because they spend, quite a bit of time in Salida and bounce back and forth from the inpatient service. It's really neat that they have the ability to follow patients, the continuity, their panel patients throughout. And I love that in a small setting. It's easy to be able to say, hey, go down to the ER and see this, help with his intubation, and go, this baby's getting delivered, or here's a trauma. And so it's really cool to be able to see them and get to help develop their training and experience here. So it's an extremely rare and really amazing opportunity that the rural track can help provide our state and our physicians. And I think we're all really fortunate.
Thank you. Great. Well, it's terrific to be able to have some of our graduates speak and for you to meet them, and especially hear what it's like to be the full circle from being a student to being a resident to being a graduate and now being a teacher. Okay, this is not advancing. Okay, so the next thing that we want to delve into is how is the work of the rural program funded? So we're funded from a variety of sources. The original funding came from a Colorado Trust grant that was written by Dr. Jack Westfall and myself. This is when Jack was the Associate Dean for Rural Health. And the department has also been a major supporter allocating the proceeds of the Thompson Endowed Chair to the rural program. The department also provides our space, our infrastructure, our IT support, and has provided salary cap coverage over the years for the faculty time that's contracted to the School of Medicine. We've had constant support from the School of Medicine deans over a period of 3 deans now. And we've had other grants from, for example, the Colorado Health Foundation and the Health Resources and Services Administration. In addition, philanthropy is really important to us. We work very closely with the CU Office of Advancement, and Marty is here. Thank you very much. This has resulted in a number of critical philanthropic gifts. The Cicada family in particular has provided endowments that help with day-to-day operations, faculty, and staffing. And the Cicada family also has provided an endowment for student scholarships and helps with our students with their housing expenses during their LIC year. Dr. Andre Huffmeyer, who used to practice in Craig, Colorado, established an endowment, as has the Moore family in Salida and the Green family here. We also get some individual gifts, including some from our graduates. And several communities in Colorado have come up with partial scholarships for our students who are willing to commit to going there when they finish their training. Those towns are Montrose, Craig, Lamar, Trinidad, and Del Norte. And we also have a partnership with CoBank, which is a agricultural finance bank that's helped us with scholarships and with some additional funding. And for the LIC that Roberto was talking about is mostly covered by the School of Medicine, and the School of Medicine is now fully covering the cost of our coordinators. So we've talked about MDs, but what about other rural healthcare needs? If you look at the map on the left, that shows Colorado's need for dentists. The map on the right shows Colorado's needs for mental health professionals. And of course, these extend to nursing, public health, other kinds of things. So in recognition of this and to share the success that we've had with the MD rural program, we worked with the CU legislative team and in some interested legislatures, and in 2022 passed the Colorado Rural Healthcare Workforce Initiative. This program shares the best practices of our rural program with 11 other Colorado public institutions and a total of 15 professions, including nursing, public health, dental medicine, behavioral health, pharmacy, physical therapy, midwifery, AHEC, et cetera. And the state funds this at $1.2 million a year. However, we were cut in half this year. We've had some private philanthropy, especially from CoBank this year, which has helped us maintain this program and add physical therapy and pharmacy to it. The Rural Program Office, which we occupy, provides technical assistance to all of these different disciplines that are participating. And we've created a learning management system developed with CUE Learning. Bonnie, I put your picture in there. We very much appreciate that. A younger picture, yeah. We now have 35 rural focused curriculum modules and have over 1,000 students in these other disciplines participating in that curriculum. So if you look at the reach of the workforce initiative, the map on the left shows the institutions and their branches that are participating. And the map on the right shows the zip codes where students from those programs are getting practical rural experience. And the box in the bottom shows the institutions that are now participating in the workforce initiative. So we're coming to a close here, but what happens next? What's next? We love our role in education, and we know that we can do more in the realm of clinical engagement, advocacy, and research, not only here on campus, but statewide and nationally. And we are involved with several national organizations and have held offices in those organizations, and we're really involved much beyond the campus. We would like every department and center at CU to have rural in their clinical care and research. We would like every school and college in Colorado to have a rural track. Imagine that. We will be part of the accelerated medical curriculum that is being developed right now in be a 3-year medical school linked with residencies, and we are involved in developing that now, and we'll do that. And there's a lot more rural focused research to be done. We also feel like we can be more involved in addressing the social, political, and economic issues that are brought to us by rural communities. You heard Roberto talk about all those places that we're involved with around the state. When we're out there, we find out about a lot of things going on. And we would like to be able to be more involved in managing those. And the fact that we have faculty, Drs. Leike and Swanson on both sides of the state give us really more reach and contact with people around the state. So to these ends, we really envision the development of a Center for Rural Health. This is very much something that we're talking about developing and getting more support for. But the Center for Rural Health would be housed in the Department of Family Medicine because of our natural inclination for community engagement and constructively interact. If you look at the center of that, there's all kinds of alphabet soup there. We're involved with all of those organizations now, and there's certainly more of them. Some of them talk with each other, some of them don't talk with each other. But we feel that we can help communicate, collaborate, advocate, and those other verbs that are circled around there to really help resolve what we have, which is not only nationally, but in Colorado, we have an urban-rural divide, which we really feel should be healed. So we look forward to being able to do that. So there's a leadership transition going on right now. The Department of Family Medicine, mainly through Linda and Colleen, did an extensive evaluation of the rural program and helped form a vision for its future. The leadership position, job description has been written and posted. A search committee has been established, and the target date for that transition is July of 2027. So that's it. That's our story, and we're sticking to it. We would like Roberto and Melanie and Addie to come back up here. We have some time for discussion. We look forward to hearing and answering your questions. Linda, I think there's a microphone going around.
Thank you so much, Mark, Roberto, Melanie, and team. That was great. So enjoyed that. I knew a lot of it, but it was so great to hear about it again. I'm so proud of you all and look forward to working with you on that Center for Rural Health. I'm wondering, you talked about this division between rural and urban. Can you reflect on other states, and is there an exemplar out there, some state that's doing this well, healing that rural urban divide, and what lessons might we learn from them?
We go to meetings around the state, around the country. We hear the same thing from other people. The world of rural training is sort of a small world, so we talk to other people. And I think that this idea of having the rural areas understand that the entities in urban areas understand their issues. Obviously, we're concerned with healthcare. So when we go to these communities, we hear from them, gee, we're glad that you're concerned about us, that you realize that we have workforce issues, that we have these other issues. So I think it's really a personal kind of contact thing. There's also other issues. There's air, there's water, there's food, there's transportation access, there's broadband access. And that's why we feel like if we have a Center for Rural Health that can talk to, we have, for example, we have a relationship with the firearm injury people. And so we've brought some of that through our students to rural communities. The ECHO program, we've helped advertise that for clinicians to get more training in certain specialty areas. But I think it's a matter of people from the city getting to know rural people and people from the rural areas knowing urban people. You know, we're all the same, but we have to understand each other's issues. That was sort of a non-answer. Yeah. And you know, we can't be, I'm from this university and I'm here to help you. That does not work. We have to go there, meet people, find out how we can work with them and go meet them where they are, just like we do with patients.
This isn't a question, but I'm taking wifely privilege to say that I get to watch you guys at home, at work all the time, and your team never stops working. There's not a weekend ever when at least one of the days doesn't involve work between certainly Roberto and Mark. It's amazing. And an important other measure, you gave so many beautiful measures of the success of the program, but another one is there's a lot of Seymours, and we get more holiday Christmas cards from rural program graduates than we do from Seymours. And so I'm just going to say, because I never will get to do this again, probably. I love you, Mark, and you amaze me. And these guys are really lucky to have more of you than I do.
Thank you. Well, it's very much a team approach. So she loves everybody.
All right. Any other questions in the room? Okay. We don't have a question online, but we do have a comment. You would like to say just kudos to the impact that the rural track has had in my life, as many others. One of the rural track students was able to follow my pregnancy, deliver via scheduled C-section, and even complete several post-delivery appointments. It was great watching his confidence grow through the process. This year, my son is in dance class with the daughter of one of the students in the program. Small world, small communities, big impacts. All right, and I think with that, that is a wrap on our last monthly meeting of 2025. Thank you for the rural program team and their students for being here today. You guys were lovely. We loved having you. And yes, please, as always, take our brief survey on your way out. We really do appreciate it. Other than that, happy holidays and thank you.